Uh, Hi, everybody. I want to thank you for joining us for this special edition of the coronavirus and the Pheo Para. I am Robert Spelke. I'm the director of the Alliance. I will be asking the questions of our two guests who've agreed to join us. I am a patient I have multiple Pheos. I'm a patient of Dr. Pochak's. I've actually been with NIH longer than Dr. Pochak. I've been there now 30 years, and they haven't killed me yet, although I keep thinking they're trying. With us today is Dr. Pochak, obviously, and Dr. Anas.
That's Anas.
Anas, sorry. This program is brought to you by the Pheo Para Alliance, whose mission is to empower patients with pheochromocytoma or paraganglioma, their families and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. That is actually I call it the lawyer definition of what we do. What we actually do is we do it for you. We do it for the people out there. We do it for Ms. Crimes, who's in Conway, Arkansas. Hopefully she's with us. And for Mr. Parker, who's in Indiana. Those people that look out and need information and support. We do it for assisting researchers looking for samples to test in Australia, which is what we've done. We do it for the people. And I think that's much more important. The why we do it is more important than what we do, and we do it for you. This program is brought to you by Progenics. For making this, we want to thank them for making this webinar series possible through an educational grant. We are now living in some unusual times. We would like your input as to how the Alliance can be a greater research to our community during this time. We believe that we are stronger together. Just to let you know, we plan to have another webinar in a few weeks. Stay tuned for more information. The surgery webinar is presently scheduled for April 22nd. Please sign up for our e-news and follow us on social media. The agenda today will be open questions. In just a few moments, we'll begin talking about where we'll be asking some questions. Some of the questions have been submitted already, but you can also submit questions online in the chat function. We're going to try to stick to questions related to the coronavirus and Pheo Paras. Many people ask variations of the same question, so please listen carefully for questions that are similar. Questions that are less case specific are appreciated. The information presented on this webinar is for educational purposes only and should not substitute for the advice of your doctor and the medical teams, because they have in-depth knowledge of your medical history and current situation. Dr. Pochak is a board-certified endocrinologist and an internationally recognized expert in the diagnosis and treatment of neuroendocrine tumors, especially pheochromocytomas and paragangliomas. He's a senior investigator in the section on medical neuroendocrinology at NIH. He found the International Symposium on Pheochromocytomas and has authored hundreds of scientific peer-reviewed articles, book chapters, and books. Dr. Anas is an associate professor at Stanford University, where his lab focuses on Pheos and Paras. The doctor also runs the Endocrine Genetics Clinic at Stanford Hospital that focuses on the care of patients and families with endocrine tumor syndromes, such as multiple endocrine neoplasy and hereditary paraganglioma. He is head of Stanford's pheochromocytoma and paraganglioma programs within the endocrine oncology cancer program. Before we begin, do either of you have anything to say to our patients and caregivers tuning in now? Anything? No?
Carol, do you want to?
I'm sorry?
No, I think,
okay.
Yeah, we can get into the questions, and I think we'll address what we have.
I think the first question, which is on everybody's mind, is that are we as patients of Pheos and Paras, are we considered those at-risk categories if we do get the virus? And if we do get the virus, what risks are we running?
Yeah, so maybe I will start a little bit, and then Dr. Ennis, can continue with the answer, because there are, the different levels how you will answer, the question that is a little bit broader question. So, as you know, for the patient with the pheochromocytoma paraganglioma, so there are several problems, and most of these patients, approximately, I would say 90%, they have elevated catecholamines. And if you have elevated catecholamines, those patients are in a difficult scenario. And that difficult scenario is coming from the problem that they have a hypertension. Most of the patients with pheo or paraganglioma, they have either the hypertension that is usually continuous, long-standing. Some of them, they have a spells, but nevertheless, they have a hypertension. And if you have a hypertension, that you have some damage of your cardiovascular system. The cardiovascular system, for example, the heart or, the vessels. And today we know that, for example, the patients who have cardiovascular problems, like, the heart problem, and we know that the patient with the pheochromocytoma may have, for example, myocardial infarction, arrhythmia, cardiac failure, because they have a high blood pressure. And if they have a long-standing high blood pressure, of course, they will have the problem with the heart. And if you look at all these diseases, they are related to the higher incidence as well as susceptibility to COVID-19. So the heart problem as well as hypertension and diabetes are one who are actually on the top compared, for example, to other diseases. And plus, our patients with pheo paraganglioma, they have a cancer. So, and the diabetes, that what I mentioned before, that high catecholamines increase the blood sugar. So some of our patients that they have a diabetes, not per se that they would have a diabetes because of some other causes, but they have a diabetes because of high catecholamine levels. So overall, I would say that the patients who have a pheochromocytoma paraganglioma, and especially those who are actually producing and releasing catecholamines, they are definitely in higher risk to be infected with the coronavirus.
Yeah, I think little to add to that. I think it was well covered. The Cardiovascular Association. I think also obviously people who are on chemotherapeutics or immune compromised would also fall into a higher risk. When you asked if there were any general comments earlier on, one thing that I would say is that a lot of what we'll say today is intellectual speculation. We're taking little what's known and what we know about our disease, and then trying to superimpose those the best we can, and can't be certain about a lot of what we say, but can give what our best idea is. And so there should be caution about the distinction between fact and what we think is probably true.
We know more about the Pheos and the Paras than we do about the coronavirus. I think we all appreciate that.
Yeah, maybe just now, maybe in a few weeks or in a few months, we'll be at the same level, because you have thousands of scientists and clinicians working on coronavirus just now, not only in this country, but worldwide. So we will see. But yes, maybe at the present time, especially from the genetics, molecular biology, most likely we will know. We know more about pheo paraganglioma, yes.
Are there additional precautions that adrenal insufficient patients should take, and are adrenal insufficient patients immunosuppressed?
Yeah. So, okay, so we'll sort back and forth, I guess. So I think our adrenally insufficient patients have to be on the lookout. Obviously, they're a special case. Are they considered to be immunosuppressed? Typically not, but if they start to develop a fever, if they have signs of infection, I think the threshold for reacting is very low, and the threshold for engaging a professional like your endocrinologist should be quite low, because this is an illness that can accelerate quickly, and you don't want to be caught off guard. That would be my take.
Yeah, I would maybe add, yeah, I definitely agree. I think that was the very good comment. Patients with adrenal insufficiency, they have usually, if they are not very well covered with, for example, steroids, they may have a low blood pressure. And here you have a situation that you get, so for example, the coronavirus infection. And of course, this infection is coming with many symptoms and signs, and we can talk about them later on. But also it's coming with the fever. Usually patients are dehydrated and the blood pressure is going down. So they are in very complicated and difficult scenario if they have a real adrenal insufficiency, because their blood pressure may be very low and it can be very dangerous. Also, because patients with adrenal insufficiency are covered with steroids, and you know that whenever you have any infection, and if you have more physical activity, you are in the situation where there is, for example, more stress. It can be psychological stress, it can be physical stress. We usually recommend to increase the doses of steroids. And here we are again in the problematic situation that, for example, if those patients will not increase their steroid doses and will be infected, and especially will be infected with COVID-19, that is really bad infection. And everybody knows right now why this infection is pretty bad and how many patients we have, with severe disease or critical conditions. That will be very important actually to increase the doses of steroids, maybe to even increase more than you increase, for example, with some other infection. On the other side, you have to be aware of something that steroids are doing, and steroids decrease the immune system. And everybody is talking about the immune system, that we need to boost the immune system to fight the infection, but not only to fight the infection, but to prevent the infection to happen. And if you have too much steroids, is also problematic, because steroids are known to decrease the immune system. So you have to balance it very well. Here, what I would suggest, that you have your doctor, you have to discuss with your doctor how to adjust the dose of steroids. I would, as an endocrinologist, I would always adjust at least approximately 20% or so from the dose, whatever the patient is doing, when there is some infection, or even, the initial symptoms. Let's say that they have some fever, they start having cough, and sweating, or some other problem, but later on has to be really very well managed by physician and healthcare professionals who are very close to a patient, to make sure that there is not too little and not too much of the steroids, because each situation has certain problems, and may affect how the COVID-19 will actually work in the body of the patient who is actually infected.
Anything else to add?
No, not too much. I think in general, I would say the patient should be less fearful of taking the medication than recognizing the need to take steroid replacement. In fact, steroids have been one of the drugs that have been trialed for the systemic inflammatory response. And although there hasn't been a lot of good results in terms of reducing the severity of illness, it isn't clear that it's worsened prognosis either. So.
Yeah, so maybe I should say one more thing, that that was not a part of the question, but I think that all patients with pheoparaganglioma should know about it. For example, you have adrenal insufficiency, but you are the patient who has the pheochromocytoma. And the pheochromocytoma can be metastatic, or you may have a paraganglioma, but you lost both adrenals because of the surgery, previous surgery. So you are on steroids, but on the other side, or at the same time, you have a paraganglioma, or metastatic pheochromocytoma that is producing and secreting catecholamines. Be aware of one situation. If you take steroids, and if you take more steroids that you need, and we discuss it, and Dr. Enns also mentioned it, that can be very good, during certain situation, and especially, higher doses are important if you have an infection. On the other side, the higher dose of steroids can increase the synthesis and release of catecholamines, and the patient may end up with a scenario where the catecholamines will be very high. And if I translate it into clinical scenario, that's with go to, for example, high blood pressure, palpitation, tachycardia, and can be devastating. So you have to be very careful. And usually when you start taking steroids, it will not happen immediately. Usually it happens in a 24 and most often 48 hours. So if you start, for example, on Monday, you have to be aware of what is happening on Wednesday, because Wednesday will most likely will be the most important day when you have to look at your blood pressure and heart rate in case that you increase steroids, because it can be devastating for some patients. I saw it several times, and I can tell you, you have to be very careful if you are increasing steroids. Yes, you have to increase them on one side. On the other side, you have to measure and follow your blood pressure as well as heart rate carefully, and sometimes you have to increase your medication, which means antihypertensives.
Okay. Dr. Ennis, I think we're going to move on to that.
Yeah.
Okay. My doctor suggested delaying my regular 6-month scan. I'm a little uncomfortable with this. How do I know if this is the right decision? I know in many hospitals now, they're not even taking what they consider non-essential patients like at NIH. But I think we all feel a little uncomfortable when we have to delay these. What are your thoughts?
So I can say that I'm doing the same decision-making. I think our definitions of who needs to be scanned are emergent and urgent. And that's usually a scenario where it's immediately or very proximately life-threatening. So I think in general, our patients don't fall into that category. I think it is uncomfortable because there's such a desire to know exactly what's going on. I think patients generally can look back at their last scan and their last several scans and realize that there's generally a fairly incremental change from one to the next. And so when we decide that, okay, we're not going to do it now in May, we'll do it in July or August, I think there has to be some balance between the risk of that short interval change versus what happens, the risk of exposure to the virus. And so it's uncomfortable. There are some patients who really want to get their laboratories redone or something of that nature. And in those cases, we have a discussion. So I think that's the other part, is make sure that they have a thorough discussion with their physician to know what's possible in the current environment, their local environment. And the other thing is that occasionally I have said, okay, this is something that you really need for your personal health. And then that begins to outweigh the risk at some level. So I have sent people for labs. In general, we've held off on scanning, which is a prolonged exposure to the hospital environment, where there are a lot of sick patients and the virus is really prominent, I would say.
Well, Doctor, can you picture a scenario where you don't have to come to the hospital to do labs? I mean, you can go to other facilities.
Yeah, that's why I say that the threshold for labs is slightly different in my mind, is that we've been using, Quest and LabCorp and other types of standard outpatient. But even there, other people who are going there, you have a risk of exposure whenever you go to Costco, whenever you go to the supermarket. And so you have to decide, is this what I need to do? Is there a benefit to me? So, and that's knowing that number typically is not a health benefit. This is long-term decision-making in general. So waiting a few months, I favor. But like I said, there are some individuals who it interferes with their life, and then they need to make a decision with their caregiver. Yeah, this is what's right for you. That's what I would say.
Right, it's a personal decision.
Yeah,
Yeah, I agree that you have to weigh, the risk and benefit, especially during this situation. Most of our patients are more susceptible, to get coronavirus, and we mentioned it something at the beginning. I agree that it has to be based on urgent, perhaps semi-urgent basis. If we have somebody who needs, for example, therapy, let's say chemotherapy or radiotherapy, yes, that definitely that patient will need to be evaluated and will need to have, for example, imaging or somebody who needs the operation because the tumor is too big. There is, for example, mass effect. Mass effect, we mean that, for example, the mass is pressing on some structures and the patient may have, for example, pain or other symptoms and signs. And the tumor is pretty big, the blood pressure is going up and down, and the patient is in complicated scenario for many other reasons. Yes, that's definitely important, and even those patients will be operated during this time, like everybody else who has, other cancers, and it's definitely needs to be urgently, evaluated, and they need to be urgently or semi-urgently treated. But if, for example, you feel, whoever asked this question, you feel that you are stable, you don't have any major problems, and your physician told you to postpone it for a certain number of months, I would here say between 3 to 6 months. We here at the NIH doing 3 months right now. We are thinking that maybe we can have patients in May. I can tell you only thinking about it does not mean that this is going to happen, but I would agree 3 to 6 months. And I'm pretty sure that the situation will be different, let's say after 3-4 months from now, because we started already in March. So, and that would be good. These tumors are growing very slowly usually. And if somebody has, for example, primary tumor, which means, just one tumor, small tumor needs more evaluation and decide about the surgery in the future, that this will be okay, and they may wait. It's really from situation to situation on the individual basis.
And the doctor has to make that at least initial decision so that they can get their patient into the hospital as a essential patient.
Yeah, I think that would be good, and I think that there should be somebody who understands the disease and somebody who has some experience, and there are some very good medical centers through this country. And I would advise patients, to talk to your physicians and ask them if they can talk with those who are specialists. We have very good specialists. We don't have too many specialists, I will be honest. But on the other side, we have some specialists and very good. And ask them to ask Dr. Ennis, to ask Dr. Fishbane, myself, Mayo Clinic doctors, some other, from Boston, for example, the Mass General Hospital, and many others. So, and they know, and I'm pretty sure, especially during this period, when we really need to support you as a patient, I'm pretty sure that we will be very happy to help you and to answer your questions.
Okay, let's move to the next question. Are you both using telehealth right now? Can you give some tips on how to best communicate with my doctor this way and make sure I'm advocating for myself? And let me just add something here, because Dr. Pathak and I actually did a sort of health communication. I had a complete workup done, and before Dr. Pathak and I could discuss it, NIH basically said only essential patients are allowed in, and Dr. Pathak and I did actually have a telephone conversation about my results. Not the best way to do it, but certainly it eased my fears and informed me of what the results were. Again, your thoughts?
Yeah, so we are, yes, as you mentioned correctly, we are using telehealth and for our patients, and we have different options. For example, we are calling patients, discussing the results with them, and that's what we do always. Okay, so whenever we have a results, and we discuss everything with the patient over the phone. The second, we offer to those who may have more questions and the scenario or situation is a little bit more complicated, they can actually be together with me and some other group members, for example, connected through Skype. We have also Zoom, and we have some other options when they can discuss with us and to go through their feelings as well as questions and how they would like to put everything together. And also we outline the plan. So we are doing it, and more than before, of course, because of this situation. But the answer is yes, and happy to do it for patients, whoever needs it in the future.
Dr. Annis?
Yeah. So I can speak to the experience in California / at Stanford. So previously there were many barriers to telehealth, in particular that it couldn't be billed for new patients. It was only partially reimbursed for return visits. A lot of those requirements have relaxed. So now we can see new patients within the state of California through telehealth and bill as if it were a normal visit, as long as we receive consent. So patients who are awaiting genetic testing, this can be done through telemedicine, because we can mail the swab, they can be taken and sent off. So that there are mechanisms to continue to have that new patient visit care done through telehealth and get some safe lab work done. The questioner was asking about a more long-term relationship they had with their provider. And I think it is important for patients who feel that they have a question that they want to have answered, or some issue that they want to address, particularly, let's say, scanning is being delayed or labs being delayed, that they have an opportunity, that you have an opportunity to present your concerns face-to-face with your physician and have them think about your concerns and reflect back how they see the scenario. And so, although we have a high threshold for going and re-imaging and maybe for getting labs, the conversation of generating a clear plan of what we're going to do in the next coming months, I think has value and is important for those who are concerned about their health, that they develop that forward-looking plan with their provider. That would be my recommendation.
Thank you. Thank you. Okay. Next question. Does the coronavirus create hypoxia? Does that make it worse for us with pseudo-hypoxia conditions already?
Of course, coronavirus create hypoxia because, that's, about the symptom signs, and about what is going on is in terms of the virus infecting especially lungs and damaging the lungs. I will not go into the pathophysiology of what is happening. A lot of the cells and cilia on the cells are actually damaged, and this is why there is a lot of secretion in the lungs and cannot go out. So the patient, they have a problem. First, they have a cough and they cannot breathe well, and then sooner or later they have a hypoxia, and those that have a very severe hypoxia, they have to be intubated. So the hypoxia goes actually together with some types of the pheochromocytoma paraganglioma, especially those that they are under so-called cluster 1 pheochromocytoma paraganglioma, those, that they have a mutation in the Krebs cycle. I don't want to be, too specific because it's for our patients, but if you have a, for example, mutation which is called succinate dehydrogenase gene mutation, that is subunit ABCD, or fumarate hydratase, or the mutation that they are actually in the hypoxia pathway, for example, HIF alpha mutation, yes, and VHL, you will definitely be in a problematic situation because you will have the hypoxia, let's say, or the patient with COVID-19 infection, even it's not critical, but will have certain hypoxia, and we know that the hypoxia may actually promote growth of tumors in general, and here perhaps, but the data is not very much available, or there are not very good studies because those studies will be very difficult, but those patients can be at the risk actually that these tumors may have some stimulus from the hypoxia, and may actually accelerate growth. On the other side, I have to say that if you have the COVID-19 infection, usually those patients recover in a few weeks. And yes, if somebody is in a complicated situation, it sometimes takes more than a few weeks and can take 2 months. But overall, the hypoxia will be not very long standing. And therefore, the effect of the hypoxia, which would be more towards like acute, it's not definitely acute because it would be only a few hours, but still, let's say we take 1 year, if somebody has a COPD or asthma or many years versus this infection, and the patient will recover and will recover well without some consequences, I think that they may have perhaps the minimal effect on these tumors. But I would say there may be some effect, but nobody knows what kind of effect. So overall, I tell patients, and especially with those mutations, I mentioned before, to avoid conditions or situations or area where they can become hypoxic.
So I would say that this is, like Dr. Patrick said, a subacute hypoxia, but our real concern here is hypoxia itself. So the threat of the illness is oxygenation. So patients are being quickly placed on oxygen. So our target saturations are typically above 93. Of course, more normal, 97, 98% is where we want to be. So anyone who's sick and is experiencing respiratory discomfort should be evaluated to see where their oxygenation is, and that should be addressed for its own sake. My concern in particular for parapheo patients might be the stress of the scenario could cause catecholamine surges. And that would be more of where I would really want to make sure I was oxygenating and minimizing stress of a COVID-infected parapheo patient. As far as long-term effects on tumor growth or something like that, I think those are secondary concerns compared to the primary illness itself, and making sure you have enough oxygen to breathe, and then your blood pressure remains under control under stressful circumstances.
Yeah. Okay, let's move on to the next question. In the absence of metastases or primary tumors, are SDH patients at higher risk for the coronavirus because the mutation causes the cell to partially rely on glycolysis for energy production, similar to cancer cells?
In general, we can so people who have an inherited mutation have one normal copy and one broken copy, right? So in the absence of a tumor, that's, as far as we can tell, functioning normal. We see plenty of patients who are extreme athletes who perform at the highest levels. There's no thought that the heterozygosity itself is a risk factor for them. That I would be reassuring generally in this circumstance.
Yeah, I agree. I don't have anything else to add to that. And if they don't have any tumors, yes, the SDHX mutations are, worrisome with some immune system. There are some new papers right now showing that most likely there is the suppression of the immune system. We don't know whether there is suppression only where there is a tumor versus, for example, if somebody is carrier. So we cannot comment about that, but overall we know that SDHX, for example, if somebody has an even small tumor, there is actually notion right now that it's going to more immunosuppressive environment rather to boost immune system in certain other way.
Okay, I have a head and or neck paraganglioma with vocal cord paralysis. If I get sick, will this affect my ability to be ventilated?
Yeah. So typically not. I mean, tracheal compression or visualization is not typically reduced. If the tumor is large enough, could there be effect that limits the ability to pass the tube or to visualize during the intubation process? Yes, but in general, our patients who go for paraganglioma removal, our anesthesiologists don't have this as a primary concern. So I would say that should be generally back of mind unless they have known compression.
Yeah, and I agree. I fully agree with that, and especially what Dr. Ennis said, that, for example, we have many patients who have had a neck paraganglioma, especially neck paraganglioma. The tumors are 5, 6, 7, even I saw 8 centimeter, and those patients were intubated without any problems. So I think generally should be fine. And today we have such good approaches that even if there is a vocal cord paralysis or there are some other problems, the intubation still will be possible unless there will be some very serious anatomic changes after maybe previous operation, radiation or something else, which I doubt. Yes, something can happen because nothing is perfect. But overall, I would say that I would not be afraid of, whether I can or cannot be intubated, because I think it will be possible.
Okay. How long can you postpone PRRT or MIBG between treatments?
Oh, that's interesting question. So you have a PRRT every, for example, 8 weeks, and then you have a MIBG, for example, Azedra or conventional MIBG, usually after 8 to 12 weeks. Conventional can be usually after 12 weeks. It really depends. If it's, but right now, for example, at the NIH, and we are doing, for example, PRRT for our patient using the Lutathera treatment, we can postpone for about 4 to 6 weeks. But if necessary, and the situation will be still problematic, and the patient may not come for the treatment, then even to postpone it, for example, for 2 months and longer, it's a possibility. It's not ideal. But another option is not absolutely sure for pheoparaganglioma, because there are only very few centers that they can use the dotatate with the lutetium. That could be done somewhere else at the center that will be set up to be actually allowed to give that type of treatment. But it would be a little bit difficult because there are a lot of protocols, rules, guidelines, and everything. So coming back to the question, 4 to 6 weeks would be most likely okay. To skip, one treatment, which would be 8 weeks, it's not ideal, but it's still possible. And this is how it is, and there is not so much data, maybe almost non-existing. But going back, for example, to MIBG previously, when patients were treated with 1 or 2 doses and then came back in 1 year or 2 years to get one extra dose or 2 extra doses, yes, it's possible. But how it will affect the treatment response and the overall growth of the tumors, I cannot comment because I don't know.
Dr. Ennis, would you like to? Yeah, well, I think what I would add is that we don't know how every different treatment regimen, how efficacious it would be. So what happens is you establish a protocol and test that and then show that it works. And so the idea is to adhere to that as best as possible, because this is what we've done before and we know it works. And then you start saying, well, what kind of variation would be tolerated? And that's, Dr. Patrick said, it's very hard to know because we haven't tested every possibility. In general, we do have to postpone and then we continue treatment. And we, at least for me, it's not clear that waiting has an untoward effect on efficacy. The other thing is that it's not clear that one dose synergizes with the next dose in terms of having a cumulative effect, so that you have to time it specifically to when the prior one was. So under the current circumstances, I would say exactly what was said, which is a 4 to 4-week, 6-week delay, that's fine. You know, or even if it's 8-week and you skip around and go to the next one, we do that from time to time when people's blood cell counts aren't quite right. So I think a lot of this is we have to take what we want to have happen, and yes, it's a deviation from protocol, but I think under the current circumstances, it's probably the right thing to do, and keep your immune system a little bit stronger.
Dr. Annas, I see that it's 12:40 here, and I want to respect your time.
Yeah.
First of all, I want to personally thank you for participating on behalf of the Alliance and on behalf of the community. Everybody who's listening, we appreciate you taking the time and answering the questions, but I do want to respect your time. I know that you have someplace that you have to be. Again, we thank you very much, and we appreciate your insights.
Well, thank you very much. It's always a pleasure to participate in these opportunities to interact with the patients I care about and take care of day to day. The Alliance is a great resource for patients. I'm sure this video chat may end, but the availability of a portal to ask questions is always open, and we're here for service. So thank you. I appreciate it. Take care.
Thank you, Doctor. Okay, Dr. Pawchuk, another question. I'm not sure this is specific to Pheo and Paras, but I'll ask it anyway. How can I best prevent infection if I'm sharing a space with a healthcare provider?
That's actually an interesting question. So of course it's not absolutely under my umbrella because I'm not infection diseases doc or epidemiologist. But you know, if you are sharing actually home, whatever it is, whether you are living in house or apartment or somewhere with healthcare professional, and you know that healthcare professional has actually, you have to know whether she or he has the access, you know, to COVID patients or does not have it. If does not have it, I don't think that there would not need to be special precautions unless you know that this patient is seeing a lot of other patients as well, because that can be administrative worker, it can be somebody who sees only very few patients, I don't know, or manager, I don't know. But if there is some contact with COVID patients or overall contact with many other patients, and especially those, for example, who may be a little bit older, who may have, you know, their immune system suppressed, I would definitely suggest you have at home social distancing. I know it sounds maybe a little bit unusual, but look here, it's not for 1 year, it's not for 2 years, it's maybe for a few more weeks. But I'm very, very careful because that social distancing is very important. Of course, you know, if that person would develop some, you know, signs, symptoms related to COVID-19, you already know what is going on, but you never know because this patient can, that the person who is living with you may develop it anytime, any minute, even at the last day of, you know, before, you know, lockdown will be lifted up. So I would say the social distancing, separate bedrooms, and being very careful, whatever you touch, and maybe even, you know, to use mask at least, you know, sometimes or some occasions. I think that would be very important. So you will need to behave approximately the same way like you would behave, you know, being at work and working with or having interaction with other people. And of course, for healthcare professionals, it's even worse, but it really depends what the person is doing, whether he's working with patients, what kind of patients. If there would be patients, for example, from oncology practice, definitely yes, must. And that has to be extremely good precaution. Infection diseases, you know, etc. That's absolutely important. So it really depends.
Okay, thank you. I have metastatic Pheo para that is spread to the lungs. Am I more at risk of getting infected or getting very sick?
Oh, that depends. It's a good question. And I understand the worries. And it really depends what is your what is the extension of your disease, what is the burden. We have many patients who have a very small lesions, like few millimeters. They may have, 20, 30, but they have a very small lesions. They don't have any symptoms related to any hypoxia, which means they don't have a shortness of breath or anything like that. They have they are keeping normal life. On the other side, we have patients who have metastatic disease in lungs, and they are not doing so well. They need, for example, oxygen. They cannot live normal life without, for example, having oxygen on usually daily basis. And especially when they do some a little bit more physical activity. So it really depends what you need or how you feel. If you feel as normal person, you do your work without any limitation whatsoever. You are exercising, even despite having some lesions in the lungs. I don't think that you need very special precautions. You need those precautions that they are actually overall given, to all people here in this country. And I would still suggest that everybody has some mask, to cover nose and to cover mouth. I think it's very important. Here we are doing it maybe a little bit less, or used to do it. Just now there are some suggestions to do it more compared to some other countries outside the US. But if you actually have the metastatic disease that already that you are short of breath, you need sometimes oxygen, or you cannot actually do some physical activity well because you actually get a shortness of breath, then you have to be extremely careful, very, very careful, because you can be much more susceptible to COVID-19 infection than any other person.
Thank you, Dr. Pacek. It's very difficult to get appointments right now, even sometimes to get telehealth appointments. Any suggestions or recommendations on what constitutes an emergency? What takes you from essential or not essential to essential?
Yeah, so also another good question. So, and I understand, and I'm sorry, for this situation. Hopefully it will be over soon, but what I would suggest, what is urgent? Urgent is if you have, for example, unusual pain. What is urgent is when you have a very high blood pressure and the blood pressure cannot be controlled. If you have a high heart rate and cannot be controlled, or vice versa, if you have a very low blood pressure and very low heart rate. So every patient with pheochromocytoma should actually have at home, some device for blood pressure and heart rate recording, at least during this period of time, maybe once or twice a day. If you have a very unusual shortness of breath or chest pain, because as I mentioned before, elevated catecholamines can actually damage the heart, and the patients may end up with some myocardial infarction or almost myocardial infarction. It can end up, even with stroke, for example. So, and when somebody has a stroke, even a mini stroke, I'm not talking about the major stroke or something that is very obvious, but mini stroke, you have to be aware of that. That's urgent. And that's actually a situation definitely need, that you go actually to your physician and discuss the situation. And that will be very important. What I would like to also suggest to our audience, if you feel that...
FaceTime video.
Say it?
No, I'm sorry, go ahead.
Yeah, and what I wanted to say that for the audience is, if there is somebody who feels that they can have urgent situation, problematic situation, and they have difficulties to talk to the doctors, whatever the reason is. So I am very much willing and open that you can send me this information email. I will be happy actually to help you or to navigate you what to do. I have to say that that is from distance. I can only recommend, suggest. but maybe it still will be valuable. And I will be happy to do it during this period of time when we still have a lot of rules and guidelines related to COVID-19. So if you feel comfortable, you can write me email and I will be happy to work with you.
And I take it, doctor, that also if you have a fever, I don't think you mentioned a fever, which is
a fever, but fever is not typical for pheochromocytoma paraganglioma.
Right,
so
for the coronavirus.
If you have a fever, it's something that goes to certain infection. So I was talking about those symptoms and signs that are typical for pheochromocytoma, and they may actually need that you will see your doctor pretty soon, or you will call the doctor and tell him, look here, I think I have something which is more urgent or semi-urgent. I need your help, I need your advice or something, to guide me through this process.
Right, and I think also everybody should be aware that if they think they have the coronavirus, that is also something that they need to go right to their doctor, because we are at risk. We are at risk.
Absolutely.
If we get
because we are all the risk of the coronavirus, and especially for our patients, and here for pheochromocytoma paraganglioma, because this is under my umbrella, I wanted to tell you, boost your immune system. This is very, very important. We sometimes forget about our immune system. We think that we will treat the blood pressure, we will treat this and that, and I understand it's very important. We have also, some of you have treatment for pain, and there are many other problems that you are going through. But another part is the immune system, and there are certain things or certain approaches that you can boost your immune system with vitamin C, with vitamin D. Usually we suggest to try to avoid some stressful situation. I know it's easy to say and it's difficult to actually to do it. But also, for example, if you can, and if you have an option to go outside under certain, the conditions and with everything what needs to be kept, to be careful to others, walk around. That's also physical activity. If you can do it, is very good. And sleep at least 7 hours per day. I think that would overall that boost your immunity. And I can tell you, immunity is extremely important. There are also some medications over the counter that can boost your immunity. And I don't think that would be any problem, to get some, because the immune system, especially in patients who have tumors / cancers, that's very important. And I very much encourage that.
Okay, the very last question, doctor. I'm supposed to go for my third, I'm going to pronounce this wrong, although I think you gave me these shots, octorotype injection next week.
Yeah.
In a clinical setting. Should I go?
Yeah, you can go if you definitely need it. Here it's, look here. So it depends why you are getting this octreotide injection. Many patients are getting octreotide injection because they have a head and neck paraganglioma, and that those tumors cannot be operated. And those patients are getting octreotide injection per monthly basis, usually per monthly basis. I can tell you honestly, even if you can go, if you feel that it will be safe and everything will be fine, which means that you are feeling okay, you don't have any signs of the infection, you are otherwise in very good shape, and your doctor will accept you. On the other side, don't feel bad or that you will, for example, skip the one injection, because I can tell you honestly, and I stand behind it, if you skip one injection or even 2 injections, nothing major will happen, okay? So that is absolutely okay. Nothing very major. You cannot skip 3-4 months, but if you skip 1 or maximum 2 doses, I think it will be still fine.
And in fact, I think I gave them to myself. I gave my shots to myself. So that's another option.
Some patients, they can do it by themselves. they have to be trained. It's not, of course, easy. Not everybody likes that,
Yeah.
but yes, they can do it.
myself.
But I really assure you, if you skip one dose, it will be fine. There will no be major effect on your tumor growth or anything like that, and especially during this period. So you have to always consider how it can harm you in terms of when you go outside and somebody can infect you, and vice versa, how you can infect somebody else.
Okay.
So
We
it's
need,
that you don't have an infection, but you never know. Okay.
okay. So what I'd like to say is, Dr. Pacek, I want to thank you for your time, your dedication to our patient community. I understand that you're going to be available next week as well for another session of questions and answers. I believe you will be. And I want everybody to please, again, sign up if they want to go through another question and answer period. The link to registration will be at the pheopara.org and on social media. Don't forget about the surgery webinar on April 22nd. Again, we ask you to sign up for our e-news and follow us on the social media. We hope that the information has been useful to you. And if you're interested in donating to the Alliance, you can do so at the pheopara.org/donate. I want to thank everybody for coming today. For participating today and listening. I want to again stress that the information presented on this webinar is for educational purposes only and should not substitute the advice of your doctor and the medical team because they have in-depth knowledge of your medical history and current situation. I send out my personal germ-free hugs to all of those friends out there. Please stay safe at home. And remember, we are stronger united. Thank you, Dr. Pacek, again. Stephanie, who's not said a word here today, thank you so much for putting this together for us.
Yeah, and I would like to thank everybody, for very good questions. Also, the Pheo Para Alliance for arranging this webinar. Of course, Mr. Spelke for moderating this session. And as he said, I will be available every week from now, this time. We can even do 1 hour, 1.5 hours. I don't mind. I'm here for you. And I know that you have a very difficult and complicated time. So don't be afraid to ask any questions or even to send me email if you need. And I will be happy to give you some recommendations, suggestion, advice. And as I said, I will be here next week the same time, and we can do it every week until everything is over and you can go to your doctors and live the normal life. So thank you so much, everybody, and it was a great pleasure to participate in this webinar.
Okay, thank you so much.
Thank you. Thank you.